So, my name is Kate Barlow. I'm the Deputy Mayor of the town of Cambridge, and on behalf of the town, it is my pleasure to introduce Professor Samar Aoun to this community talk today. Samar is Parents Institute Research Chair in Palliative Care at the University of Western Australia, Head of Palliative Care Research at Parent Institute, and the WA Australian of the Year. So we're very fortunate to have such a significant person versed in this area that's going to speak to us today. Samar is an international leader, an innovator and a champion of practice and policy transformation of public health science for palliative care. Samar advocates for person-centred health care, which is very important, and social care. Her research programs on the social model of bereavement care have informed policy and practice at the national and international level. In addition, Samar holds a number of volunteer roles, such as Chair of the Motor Neurone Disease Association, and at the state and national level, co-founder of the Chair of the South West Compassion Communities Network. In her talk today, titled Growing Compassion in Life and Death, where she will share how we will have a role to play in growing compassionate communities in partnership with health services and local government. At the end of the talk, there will be a short question time, and you'll be able to have the opportunity to chat with Professor Samar over a cup of tea after the presentation. So please welcome Samar to the stage.
Yeah, it is absolutely everybody's business, compassion. And I'm sure I'm preaching to the converted today. So you're all compassionate, you're all here. We've got Rotary clubs. They preach compassion all the time. They act in a compassionate way. So welcome, everybody. It's really nice to see you and to share this journey with you, because you've all been there, you've all done that. But how can we as a community pull together to actually make a significant difference and make palliative care accessible to everyone, everywhere? We've got fantastic palliative care services, but it's still not accessible to everyone, everywhere. So let's see how this can be done. And I'll thank you, Kate, for your introduction. It's lovely to have Kate from a nursing background. She's worked in palliative care as well. So very fitting to have met her today, and hopefully we'll have more to do with the town of Cambridge. So where is compassion? We all have sort of different ways we think compassion is, but I found this definition really, really nice from the NHS. We respond with humanity and kindness to each person's pain, distress, anxiety, or need. We search for the things we can do, however small, to give comfort and relieve suffering. We find time for those we serve and work alongside. We do not wait to be asked because we care. Does that sit with everyone? Yeah. So what is compassionate communities? It is really the old way we used to do things. We were born at home and we died at home. How different is it now? And that's not a good thing for humanity. So it's an idea, it's a practice, it's an aspiration. It's inclusive of everyone. Doesn't matter what disease, it's about suffering. It's committed to system change, and this is where I'm going to mention how we did some system change with the health services and with local government. And of course, this today presentation is a partnership between the Parent Institute, fantastic place to work, and of course the town of Cambridge, where we're hoping to do more work together on many things as well. So it is also, compassionate communities is a key element of a public health palliative care approach. What does that mean? It means that the community needs to be an equal partner in the long and complex task of providing quality healthcare at the end of life. We are partners. At the moment, we are not. And this is where, I'm hoping everybody will take out of this today. So internationally, it's not something that we've created here. It's an international movement because there are gaps everywhere. And it's about giving the social and practical support at end of life, and it's gaining momentum all over the world. We need a shift in the culture of care and support, and care becoming this way more sustainable and affordable. And there's high level of community control and ownership, and you can do it. And I'll show you why and how. Now, I'm a researcher, so I really need the evidence to be convinced about everything, and everybody else is the same. Show us the evidence, especially, health departments or anybody who wants to give funding in this space. Now, we have showed that person's day, only 5% of someone's day, whether they have life-limiting illnesses or other illnesses, is spent with formal care, whether it be in a doctor, a nurse practitioner, social worker, any allied health. What happens to the 95% of our time? Where do we spend it? With us, with the community. Who are the people depend on us in their hardship, in their sickness, whether it's the spouse, other family members, neighbors, workplaces, community agencies, faith organizations. What are we doing to the 95% of those assets in our community? They need to be there. They need confidence to be there. And I think this is what the Compassionate Communities movement is about. When we did our bereavement survey, for a while, everybody was not knowing exactly who do we need to give bereavement support for. And they thought everybody who has a death in the family need to go to a counselor. This is how the field was moving. So the idea was, as researcher, we said, well, let's ask people. Very simple. If you don't ask you who actually helps you, we won't know how we're going to influence the system. So 1,000 people answered from all over Australia, and we used the databases of funeral providers because our death registries here, privacy issues, they wouldn't let us go near the next of kin so that we can ask them how they dealt with their bereavement. So the minority had used a counselor, a social worker, any health professional that's in that space. About 30% used people in the community, like us, who have been able to help you, whether GP, pharmacist, hospital. They're not really specialized in bereavement care, but they can help. The majority, families and friends, 90%. Funeral providers, they were really surprised. People really relied on them quite a lot. And hence, since that research was done, they really stepped up into being, having more grief support for the families. So this is the lay of the ground, basically, in our community. And that's not just in Australia. A lot of other countries have used that survey, and it's showing the same thing. This is in developed countries, rich countries. So we know now that the family, the friends, have a big role to play when we didn't know before. And this is the first empirical evidence we had that the community can play a big role in this. And hence this pyramid about how do people need support and the low risk, moderate risk, and high risk. So 60% of people, when they have somebody who dies in their life, are low risk. It's normal risk. Majority of individuals can get help from their families and friends. Moderate risk in where, life and death have been a bit more complicated. They need additional support, like the peer support volunteer-led group, which I will talk about one example. And then only 10% are at high risk, which is great. That's only 10% who are at really complicated grief, and they need mental health professionals. So when we ask them, how helpful was this support to you? It's great that they're using families and friends, but are you helpful? When you look at it, the blue line, people saying, yes, really helpful. The red line is not so, And again, family and friends showed that they are really helpful for people in their bereavement stages. So no doubt about it. And you can see the red lines are a lot more when we come to the sort of professionals, when some people felt that, no, it wasn't that helpful for them. So we've got the evidence, people, so let's act now. This is what I'm saying. This public health model for bereavement support has been translated everywhere in the world. Now we know how resource allocation needs to happen. And what brought me into this field is that I was asked by the Commonwealth federal government, the health department, where do we need to spend our funding for bereaved people? And then when they got now the 3 levels, they're quite okay where the need is and what they need to do and what us as the community need to do. Now, as the WA Australian of the Year, I had that many interviews, and people like to have a personal story. I didn't realize as a researcher I've never spoken about my personal stories. It was all about research outcomes. How are we going to improve the system to everybody? So when I reflected back at about what are the key sort of issues that made me interested in this field, when my dad died in 2012, I was preparing myself to go to work. I was going to chair a research meeting at my old workplace. And so I called the office to say, look, sorry, I just got this news, my dad died. I need to book my flight to Lebanon. This is where I come from originally. It takes me a whole day to get there anyway. And they told me on the phone, you must come really quickly. We don't wait to bury our dead. Yeah. So anyway, I sent this message to the office, booked my flight. And so I was on Australia Day, the following day to Lebanon. And I thought to myself, let's go back and join that meeting, So I walked in, and I had about 7 of my colleagues there, of all sorts of health professionals. No one asked me how I felt. I just thought, there's something wrong. It just didn't sit with me. I'm sure they didn't do it on purpose, but a lot of people don't know what to say, even health professionals. It is a problem that we've never had those conversations in the community to know what to say and to help people. And of course, people are afraid to say the wrong thing. And this is where I'm saying education and awareness in the community is a must if we are to be equal partner with everyone. So anyway, the following day I was on the flight, and I must say that was the first sort of a funeral of somebody really close to me. And I was just overwhelmed by the love, the affection. I just felt I was carried on a cloud all the time. It was like a surreal feeling for that 3 days of mourning that we had in the church hall. And I've had everybody who we knew my parents, my grandparents came. We ate together, we laughed together, we cried together. And then I felt after 3 days, I'm fine. So back home, my family were really worried that, I'll need a lot of support when I come. And I said, no, I'm fine. But the great thing about it, I've discovered something. All the way in my flight, I was saying, wouldn't it be nice to get that feeling that I had in Lebanon back into our society here? It'd be nice to have that balance, what we have here. So, and this is what sort of, I started then researching compassionate communities and thinking, how can we get this happening? And there is a lot of things happening in the world in compassionate communities. Certainly, we haven't discovered ourselves here. But again, how do you prove that it works? What is the evidence behind it? And that's what I'm going to share with you now. So when it comes to bereavement support, the Palliative Care Australia have got a standard on grief support in their formal publications. The Irish Hospice Foundation have used that to develop their policies for adult palliative care. The National Bereavement Alliance for Children in the UK, they were the first ones to actually contact me and say, thank you for your work. It's made so much difference for us. We're able now to know what to do, basically. The European Association of Palliative Care, they developed their guidelines based on this. King's College London, they kept telling us what wonderful work, and we've got some external paper, the best one for that time. And again, it's the practitioners that matters to me as well, because they're on the core face of really delivering that support. And again, they said this triangle has meant so much for us and for our practice. So, how are we doing in Australia? In the next 25 years, the number of people who are going to die is going to double. We're not going to have a palliative care service at every street corner, and we don't need one either. And unfortunately, a lot of Australians are saying they're not dying in a way that fits their values and their choices. But do we know their values and their choices? We're not saying it. And also what happens is that they keep going into the hospital all the time. And that's really very, very sad at the end of life to go there with the lack of dignity, lack of control, and the lack of choices that they may have. So we need to change this. This doesn't need to be like this. Now, the guru of compassionate communities, Professor Alan Kelleher, said, death is a social event with a medical component. It is not a medical event with a social component. So let's bring it back to a social event. Death has become too institutionalized and professionalized, and it doesn't need to be like this. Because the reason why is that when you have in a country really good health services, the community tend to step back and be de-skilled. And they think, no, we can't help. The professionals can do it better. Well, there is a role for them, and there is a role for us. So we need to bring back that confidence into our life. As you have seen, the research has showed that we are doing a good job. So, more statistics on Australia. Dying is increasingly becoming institutionalized with 25% increase in hospital palliative care admissions. Spending on key health services is 14 times higher for Australians in the last year of their life than for other Australians. You could see the difference in dollars. Hospital is 3 times the cost of community palliative care. Now, 70 to 80% of us want to die at home, whichever country you're in, but only 14 to 20% are achieving this. 14 to 20% are dying in the hospital. 75% of Australians haven't had end-of-life discussions. And less than 10% of us die with advanced health directive. Nearly 50% of over 60 years old are at risk of social isolation. And this is the biggest killer of our time at the moment. We are so globally connected with all this IT and everything, and so locally disconnected. We're not seeing each other enough. We're not hugging each other enough. I mean, of course, COVID-19 put a dampener on all that, unfortunately. And on 1/3 of us will experience some degree of loneliness later in life. That is really sad. We need to do something about this now. Do not underestimate the impact of social connectedness. It is a health determinant, and mental health and physical health. People who are more socially connected are happier, physically healthier, live longer. People who are socially isolated, totally the opposite. Less happy, health declines early in midlife, brain functions decline sooner, and they live shorter lives. And that's research that's been done in a big trial. The other proof as well is that social relationships, those who have really good social relationships, have a better impact on reducing mortality than if you stop smoking or reduce your weight or reduce your blood pressure. That's amazing. This is thousands of people in this trial. So you cannot underestimate social relationships. And the reason was explained to me by medicos is that when you meet somebody and react with them, a lot of neurological, biological things happen in your body and your brain. And that gives you that feeling of happy and goodness within yourself. We need that as humans. Now, there's a lot of apps around as well, and this is where we can. I'll talk about apps later. How is this bringing people together? Like, instead of meeting somebody, giving them a hug, having a cup of tea with them, we send something by app. No, it's not the same. Anyway, benefits of a compassionate community. People with a life-limiting chronic illness and their carers are better supported. Increase of equity of services. People have a sense of purpose in supporting their community members. People learn how to care for one another, end of life, and can share this with others. And there are financial savings. So all around, it's a win-win situations. Now, the first one that showed there are financial savings is Dr. Julian Abel, who's a retired palliative care physician in the UK. And he did this trial with the GPs in a small area called Froome of the Somerset. And he showed that 2 years later, there was a reduction in hospital admissions because all these lonely people, all these people with comorbidities, they had people in the community that helped them, look after them in their own homes. So when you look at all this, we need to do something. This is where we started in the Southwest Compassionate Communities Network. And our motto is every person, every family, and every community knows what to do when someone is caring, dying, or grieving. And it'll be great to have compassionate communities all over. I mean, people are compassionate anyway, but the feedback I'm getting, it's nice to be part of a community that cares, and we all are together doing this. There was a call to establish a compassionate communities. By the way, everything is free and volunteer, so, but the groundswell said, would you like to put an expression of interest? So we did. So we were the only one at the time from Bunbury. A year before that, Albany had started with funding from the WA Primary Health Network. The Bunbury model started with grassroots level. It was me and another, the co-founder, Dr. Julianne Hilbers, who our dad died around about the same time. And we were discussing about how was your experience? How was your, and we thought, well, we need to start something. And this is how we started something with the Death Festival. But that was something, wow, in Bunbury, like, my goodness. We had it at the Bunbury Recreation, the Breg and Entertainment Center. And I can't tell you, a few people said, how dare you do such an event in a lovely venue? Why? 100% of us are going to die. This is for all of us. Like, what is it we're hiding from? And so slowly by slowly, I think the Southwest community, because we did so many of these activities and brought them together to have those conversations, they don't feel like this anymore. So this is the lovely group of volunteers who are on the committee, and we have people from the health service, people from local government, people from Bustleton Hospice, from the volunteer center. So we're all together trying to get this vision out. So this is the first group of volunteers. They're called the Compassionate Community Connectors. Now you can tell this photo was taken at COVID time because we all had to stand so far away from each other, which is a bizarre photo to have. But that's what the health service wanted at the time, and that's fine, we can work with that. So the Compassion Community Connectors model of end-of-life care, we wanted to develop, implement, and evaluate the model of community volunteers to support people living with advanced life-limiting illness and palliative care need, develop and evaluate a training program so that we're all doing the same thing on the same page, and then is it feasible, is it acceptable, let's see, is it effective? This is what we needed to find out from the research. So the training program, basically, we talked about compassionate communities, understanding advanced illness and what palliative care teams and chronic disease teams do, death literacy, advanced care planning, grief literacy, communication skills when people go into people's homes, confidentiality, self-care, what are the boundaries and the endings. At the time we were doing the research, so they understood about why we're doing the research and the protocol for it and the evaluation tools. And of course the WA Country Health Service had their own regulations and protocols and all that stuff, which is fine. It was a really great partnership between the community and the health services, which it's very rare. It hasn't happened anywhere else. And tomorrow, we'll be presenting to an international audience on this because there is a lot of interest in this model. To have a health service work so well with the community, was deemed impossible. So they want to know how we did it, basically. We'll see. Anyway, so we did an evaluation for the training program. The blue line is the increase in self-confidence that the connectors had in dealing with death literacy and grief literacy, which is great. So we know the training program is useful. So we had to work with 3 groups, the families, the patients and the family carers, the connectors, and the group called the caring helpers. I'll explain about them. So the connectors undertake network mapping. The connectors go to the family and say, okay, you need help in XYZ, when the family tells them, who in your network can help you? Whether your internal network or the external network, and if you don't have anyone, we'll get someone to help you, basically, if you accept help. Now, the other thing that we've lost in our world, developed world, we've lost the skill to ask for help. It shows we are weak. It shows we are needy. It shows we are, Unfortunately, what I said to the families, if you don't ask for help, you are de-skilling your community from helping you and helping other people because they need to practice on someone, right? And otherwise, we don't build the skills. It's a natural way of helping each other. So when people ask you, how do you feel, and they know you've got cancer or motor neurons or something, Oh, don't say I'm fine, I don't need help. And of course, the people in the survey regretted saying this, because the moment you say no, you've shut all the social networks around you for any help. Because people are not going to come back and ask you again, because they feel they're imposing, right? Said it once, you could say, well, great, but could you call on me in 2 weeks' time? I'll be more ready to accept the help, or something. Not say, no, I'm fine, because nobody with a terminal illness is fine. We know that, okay? So, but it's just that stigma and taboo that we need to really, correct. So we all work in these circles of care, basically. So we've got the family in the middle, the inner network, the close family, and then the extended family, and then the community at large, and then the health professionals are part of delivering all that care. So it's about enhancing those networks, activating them, mobilizing them around the family that needs help. And this is what the connectors do. They tap into, where the need is on behalf of the family, and teach them how to do this themselves. So the caring helpers are those people in the community who are happy to give those help. So whether it's walking the dog, doing the shopping, collecting a prescription, going to the library, mowing the lawn, making a snack, tidying up, sitting with a person who needs a break. Now, you may think, is that all? These are really little things, but that made a lot of difference for people, because it gives them their dignity back, makes them feel that they can keep going with their life, although they are very sick. And it's not just here, it's really all over the world when this research was done. So little things have got big effects. And the most important thing is that sitting with a person and having a cuppa, that cannot be underestimated. So the families who were referred from the health service to the program are those who have a high level of unmet need and low social networks, like they don't have people who could help them on a regular basis. These are the domains where the help was given: personal care, medical, home, transport, social, food, pet animal, preparation for end of life. So 20 connectors did the first training in July 2020. 13 connectors participated. And again, it depends when you can participate, when you can't. But the knowledge is there. We ask everybody to come to the training program, and whoever wants to stay part of that program is fine. But then they've got the skills anyway to do it in their own community, so that's fine. The median age of the connectors was 62.5 years. Follow-up of families, the median was 18 weeks. Some of them only needed 3 weeks. Some of them needed a year. And the average number of families per connector, some could have 1, and some could have 9, within like months and months of help. So it very much depends on your own life situations, your personal situation, how much you give help. But that's, again, the same. If you have a neighbor that needs help, if you're going overseas, you just say, sorry, I'm not going to be around. Then you come back and you check on them. So it's not a big deal. There is no boundaries around this in terms of when you can help and cannot help. Now, we asked the connectors at the time, part of evaluating this, can you mention all the time how many contacts and hours you're spending? But it's an underestimate. They just hated filling forms to say how much time they're spending. So it could be face-to-face, it could be on the phone, it could be text, it could be email, it could be like any way of connecting with them. So community volunteers are trained to diagnose suffering, not diseases. We had 85 families referred from palliative care and chronic disease teams. We started with palliative care, but we found out that because palliative care services have their referrals too late, health professionals are not referring to palliative care in a good time for that rapport to happen with palliative care services. So by the time they're referred to palliative care refers to the connector program. They've got 1 week, left to live. Like, they can't really build their communities around and be part of that. So we lost about half of those families, basically, who were referred. Therefore, we went to the chronic disease people, so basically starting upstream. And we ended up with 43 families for that period, a year and a half we were collecting the data. 47% were home alone. This is where our health services are struggling with people who have no one. It's not like they don't have families. They're disconnected, big way. Median of age of patients was 74. Well, they varied from 34 to 90. 44% were male. Oh, Cancer, 47%, cardiac respiratory, 33%, and neurological, 14%. Now, along when we're doing this, the Australian Bureau of Statistics said that Bunbury is Australia's region centre of people living alone, which I thought, that's interesting. I mean, we've got a record, but it's not a really good record, is it? But anyway, I thought that was a piece of information worth knowing. This is where the families came from, mainly Bunbury and, of course, the regional centres, Bunbury and Busselton, and then from the shires around that. Now, look at this. Where was the need most pronounced? What did people want from our connectors and caring helpers? Social support. 80%, nearly. They want social support compared to all the other needs that they could have. So when I say social connectedness is so important, again, the evidence is there. People want people with them. So what did the connectors do? Professionals to come to do home visits for wills, advanced health directives, help with my aged care applications. They did, of course, the liaison with service providers, equipment access, meal delivery, organizing meal train, organizing house cleaning, joining community groups, all-time dancing, crafts, walking groups, men's shed, surrogate grannies for family with kids. A young mother who had cancer, had 3 kids at home, couldn't send them to daycare because they will pick up all these germs back to her. So the grannies surrogate grannies, they came and helped, which was great. Transport to medical appointments or social occasions, gardening, firewood delivery, social visits. The most important thing, empowerment and ownership. You can do this. Because if you live by yourself with a terminal illness, you lose that empowerment completely. So when we look at the caring helpers, where did they come from? Again, not a lot from family and friends, because we had half of the families with no family and friends. Community service groups, 18%. Individual community members, 25%. Like, I give you one story. One lady who had a lot of comorbidity, she moved to Bunbury from a smaller town, but she just couldn't put herself in the car and go to find out where the supermarket is, where the library is, and she was so confined in her home all the time. So I reached out to a Rotary Club in Bunbury. I said, have you got somebody who could sit with this lady and just show her around? And this is it. One of the spouses, came with her, did 2 or 3 trips with her, showed her how to drive around Bunbury, gave her that confidence, that support. That's all it's needed, for this woman to say that her life has changed, her world has changed from a golf ball size to a basketball size. It's opened her world for her. Those small gests, but if we don't know that people need them, we can't offer them. So this is what I'm saying. So basically then the help came only 26% from the naturally occurring networks, those, the inner circles, and they came mainly from the facilitated networks that the connectors were so resourceful, they were able to find out who's able to help them in the community. And the good thing, they stayed friends. It's not like those external people came and then left. They became part of the life of those people. So we measured social connectedness by this validated tool, which is used internationally, and there were 2 subscales. There is practical and tangible support, and we asked them before we had a connector and caring helpers help them, and one after. So do you have someone to help you if you are confined to bed? Someone to take you to the doctor if you need it? Someone to prepare your meals if you are unable to do it yourself? Someone to help you with daily chores if you were sick? So that's the practical support. The social and emotional, someone to have a good time with, someone to turn to for suggestions about how to deal with a personal problem, someone who understands your problems, someone to love and make you feel wanted. So these are the questions, the before and after the interventions. Look at that. The blue color is where we've increased the social connectedness from before the intervention, which is green, again equally in the 2 subscales. Then we looked at the need of these families, how dependent they are on people need to help them, and the availability of their support networks. And again, we had a scale here to use. So while their needs stayed the same, because obviously they're people with life-limiting illnesses and they're dying, the dependency stayed the same, the green and the blue, the first bit is the same, but the next one, the availability of network support, we've doubled their network, basically, of support around them. that's the only way for people to have good quality of life and good quality of death. Then we asked the families, what was the highest impact that the connectors or that program had on you? Again, as you see, the orange one is the families, we call them clients as well. Reduce social isolation for them and basically help them coping with daily activities. The orange most pronounced. Now, we asked the connectors, where did you think you have the most impact? They were so humble. They just felt they didn't really do a lot for these people because they kept saying, my goodness, the effort is smaller than the reward. Like, they were surprised that the families had really appreciated their needs. So they've always, so what happened is that they marked themselves lower than the families had marked them on this scale, which is, again, something that the volunteers are so modest and they don't want to, they're at the background all the time. So this is to show you how one family before the intervention, what kind of support they had, 2 neighbors in the community, 2 family members, 3 friends, and so on, and the formal services. Now, when the connectors and the caring helpers came in, you can see all the buzz in the connections that has happened, for that family. They were more connected, and even the people who helped them started being more connected around them and sharing, how they can help them in which way. So that's really fantastic how, people started coming together. Now, not only that, it was all really lovely social connectedness. There were some important as well health service utilization outcomes. So with the effectiveness study, we showed that there was a significant decline in the frequency of hospitalization per month for the group who had the connectors and the caring helpers. Why? Because those people with comorbidities, they tend to freak out a lot more on the weekend when there are no formal services. And even if you want an appointment, it takes ages to get one. But they've got around them their community now. They've got the connectors. They can call them at night, on the weekend. They come and sit with them, hold their hand, give them that comfort. So they don't need to go to the hospital. They don't admit themselves to the hospital just for social admissions, because they're too scared to be by themselves. Now, the other thing is that significant decline in the number of hospital days. They don't want to stay as long now because they've got people who love them in the community. They can go out and resume their life. They don't need to be in the hospital because they have no one around them to help them. And then the other one, increased use of outpatient services. And the reason behind that is that the connectors were making the appointments for them. Now, who wants to be on the phone for so long when you're sick and disabled to get a community-based referral, So the connector said, no, I'll do it for you, I'll help you. And then they transported them to those appointments where before they had no one to take them, so they stayed at home and missed out on all this. And then they became really, really sick and they admitted themselves to hospital. Just makes sense. So this is great. So I'm really now going with this information to the state minister and the federal minister to see what we can do with that. Now, the net savings of the connector program was on average over $500,000 over 6 months. But that's in those savings only. Can you imagine the savings in all the other ones that we haven't really measured to that extent? So it's a no-brainer, We really need to be there. And I think what I would like to happen is a national campaign of education and awareness for the community in general to know that they can do that, to empower them, to give them the confidence. And we have a training program now, for the connectors. So it's a matter how do we get that publicity in the newspapers, in the TVs, in everywhere, so that the community can start taking action. Now, I think Rotary clubs can help with this. So I can be talking to you as well. This is really community work. So we did interviews. So not only that, we talked to the families, what was it like for them. We talked to the connectors, and we talked to the health professionals. So the patients and carer feedback always keeps her promises. This is about the connector. A lot of paid carers really don't care, just filling in the hours. She goes above and beyond and seems to care. She knew when we were a bit overwhelmed, knew when to get involved and when to step back. Necessary for people who don't have strong existing networks, for people who are isolated, it will help open up their world. I can ask her anything, no matter what I talk to her about, she always has a sensible answer. Now, those first, the connectors that are coming volunteering are all with lived experience. They looked after more than one person with, life-limiting illness. So they already had a good grasp on the death literacy, and the grief literacy, which is great. That's why we didn't need to tell them anything beyond that, day of training. But we connected with them every 2 weeks on Zoom, all of us. And for me, it was just learning from them how they're doing things in the families, which was amazing. And then the other connectors would learn from them and exchange things. Oh, I did it that way. Why don't you try that way? So they were basically a really good support group for each other. Pretty amazing about this program. This is one lady who's saying that her caring helper is her legs. She's got COPD, homebound, on a ventilator. This is a man his garden was his life, but he couldn't do much anymore, and he became really depressed. I think he's a bit poetic as well, spoke of a blackness that would flood over him and loom for days like a heavy rain cloud. That blackness has gone. So this is a church group, as you can see, multi-generational. They came straight after Sunday service, and for a few times they came and sorted his garden out, and he became a different man. He went to dancing afterwards, it's just amazing the effect it had on him. What did the healthcare team say? Really positive, especially for clients who are early in their journey and for those who are isolated, don't have a good support. I would be encouraging more people to make use of informal networks and support, and that's great from somebody who is a health professional who thinks for everything they need to tick boxes or refer to a paid service. Now they're telling the families, think, who have you got around you in your family, in your community who can help? We'll ask you. We'll help you to connect, She is very socially isolated, and our professional service is not enough to meet her social needs. So I'm very happy for her that she has a consistent person to talk to. Added another string to our bow, especially in small rural areas where there is a lack of formal services. Easy to implement. This is what we want to hear from a health service. It's not going to add more to their woes. Now, what did the connector say? Great to be given someone specifically to help fill their needs and tick their boxes. So rewarding to watch their quality of life improve. Being able to connect to those in need has brought very obvious benefits to both the volunteers and the receivers. The more you give, the better the reward. The reward is greater than the effort. This is what actually exemplifies the volunteer, psyche. Fabulous program. So I'm going to show you now how these connectors had operated in people's home to give you an idea about the discussions and everything else. So see if I can work it out properly. Here we go.
I think the community needs to be there to support. Death's not a secret, but sadly we often treat it as a secret.
I'm a New Zealand-born Māori, and I met my husband Malcolm at Teachers Training College in New Zealand in 1970, and we married in 1972. I guess I can describe Malcolm as he didn't have any enemies, and there wasn't anyone that didn't like him. Because he was strong, he was frightened about dying.
I met Gus in 1980 at the Blacktown Workers Club, mid-year, and 5 days later we moved in together. So we've been together nearly 41 years. We married in 88, and by that time we had 6 children, so we're a blended family. Gus had 2 children, I had 2 children, we had 2 children. Gus was very, very fit. He was, he'd gone back to uni as a mature age, around about 60 years old, I think he went back. He loved books, writers, authors, always had. He always thought he had a book in him, they say everyone has, and he did have. And then he became ill, and we never thought it would last.
For the first few days, the doctors were saying he's got a very big growth on his lung, and he would not be surviving probably days. You know, it wasn't going to be long. And so, because he didn't want to die, he wasn't ready, we asked really that we go somewhere that we can, you know, help to. The doctors were worried that we were trying to prolong Malk's life because we didn't want him to leave, but that wasn't the case at all. We didn't want him to leave until he was ready to leave, until he was ready to die. So, in there I looked at the compassionate program and asked to join and be part of it.
To have Gus suddenly, very, very suddenly unwell, it just threw us in a tailspin. I think everyone knows they could get sick at some point, but you never think it's going to be you. And we never thought it'd be permanent.
You know, we still have kids sitting in desks. I came into contact with this connection, this program. There was something left after a meeting in hospital, and I looked at it and wondered about it, and had put our names down, talked to it about it with Malk.
I had the privilege of coming in and meeting with Mary and Malcolm. I could see they both had needs. Both were so loving towards each other and were so worried about the other person they weren't discussing their individual needs. My role was to come in and I guess get that conversation going. Both incredibly capable people, and I saw myself as being an advocate, just to slow them down and say, what do you need? Yes, you're capable of doing that, you can do that, you're intelligent people and you're in control of this situation.
It was wonderful meeting Jenny, and we got on straight away. And she's the type of person that you can talk safely with, if that makes sense. That you can sit down and you can have a conversation and talk about things that you can't talk about to other people, about how this has impacted on your life, and be honest. You don't always get the opportunity with family or friends to be honest.
I do a lot of listening with Jenny, and with Gus I was able to get a retired principal to go in and spend time with him. Gus is a very academic man and he likes an intellectual conversation, so it's sort of finding people that kind of meet that need. Yeah.
On end-of-life care, upskilling the community is a really key point that we are working towards in the Compassion Communities Network. There's nothing worse when, you know, somebody dies and then the family is lost. What do they want? We've never had that conversation. And I think this is where the community needs to focus on, and I think we will get a much better advanced care planning than, say, a clinician doing this in a hospital or a clinic, because we're talking about a life.
No one wants to feel helpless, and it took me a little while to realise that this wasn't so much about helping, it was about supporting and being beside people during times when they otherwise couldn't cope on their own, and that was me. I was just overwhelmed.
I would have completely, I believe, fallen over if I hadn't had the compassionate program and being involved with Jenny and the compassionate program.
Nobody wants to die, but if people are allowed to speak about their fears around death, I think it makes that process more bearable for them and those that love them.
Yeah. What did you think? They do such a marvelous job. So, what is so distinct about this form of volunteering? We have hospice volunteers, we have volunteers in hospitals, we have this kind of volunteering exercise more autonomy and have more agency in providing care. They don't come back to us and say, oh, can I do this, can I do that? They do things as you do it in the community in general. It's very organic, like they don't need permission. They don't need, we're learning from them, really. It's a way of have sustainable social capital, because that's emerging from genuine social encounters. They become friends, they become part of the family, if they want to. I'm not saying it needs to be. Again, these are boundaries that probably do not sit well with other volunteering system. And then these volunteers have done volunteering in every different way. So for them, it's fresh ways of engaging with the community. So these are the two quotes from some of them. It's not a walk in the park, like other voluntary positions I've had. It's a whole different level of commitment. But I would do it again. I highly recommend it. It's a lovely way to do volunteer work. If you really enjoy being with people and talking to people, you end up, I don't know, being part of their lives. It's really fulfilling in that respect. So we've got all these articles if you are interested to read academic ones or any details. So, let me know. But they are all open access, which means you Google them, you find them. Because we've had one about what the connectors said, about one what the patients have said, the family carers, and about all the evaluation in general. Well, we nearly got the award 2 years ago, a palliative care award, so we'll try again this year now that we have finished the program. We were just starting then, so these are some of the lovely connectors at the award ceremony. Now, where do we go from here? We've got all these wonderful results, and we've got wonderful community that's ready to be part of it. So the first sort of hurdle was great. We got the health service now integrating it as a program as standard practice. And the coordinator of connectors, that's the only paid position, the coordinator of connectors, is now from the health service. She does the chronic disease management work. And so that part of the connector work has gone embedded into the chronic disease group. So she does both, but she gets help with her other work because she knew the program really well. She was referring to the program. She said, I can only deal with the clinical needs of my patients. And I was really struggling with all the practical and social support. So I used to refer a lot to the Connector program. So it makes sense. It's a continuation. And it's that holistic care, basically, in palliative care. It's about looking after everyone's psychosocial, spiritual, existential, family care support, and, of course, then bereavement support as well. So that's great. And hopefully we will be able to replicate this in with other health services. Again, a lot of communities ask me, how can we start a compassionate community? I would say, look, it's got to be driven by the community. It's not by the health service, but the health service can be partners with you. And to start with the Connector program, that is really a good way of, sort of focusing on that kind of work to start off with, and then things will grow from here. We need to bring the GPs on board to refer to that program like they've done in the UK, so that's on the agenda basically. And then local government, and I think this is where, it's interesting that, we have at least Kate here. Anybody else is from the town of Cambridge here? Oh, great, okay, lovely. So we've had this program, but then again, of course, it's still small. How do we get the community at large acting in a compassionate way and saying compassionate things? So it's about having a compassionate charter and, in collaboration with local government. And this is what other, countries of the world have done. So we have had many consultations with the community over 2 rounds, and we have now a document called the Compassionate Bunbury Charter. So this charter will guide and encourage the Bunbury community, including individual consumers, service providers, businesses, community groups, schools, clubs, to work together to create a more compassionate Bunbury city, Cambridge, whatever, the city we are in or the town, that is more resilient, responsive, and understands the need for community support to get through difficult times. And local government is the layer of government that's really closer to the community with all the programs they do and everything. So we really need to, work with them to get that happening in every local government. This is what now, from community consultations over months and months, what we ended up with that summarizes this. So it would be about building capacity to give and receive, mobilizing networks of care, supporting good communication, respecting people's wishes, fostering belonging and connectedness, providing opportunities to remember, nurturing creativity. The arts sector is very important to be, and the music sector. We need to have leaders that champion care and compassion in their workplaces, in their schools, in their organizations, wherever they are. We need to create caring organizations, acknowledging compassionate acts. And I think, it'd be nice along the line if we have an award from the mayor once a year to acknowledge compassionate acts or the most compassionate workplace or the most compassionate school, to make it visible for people. I think we need to really agitate all this now. So where we are with that now is that it's gone to council. So we'll have a meeting with them, have some endorsement there, and then we start working with, we have work to do with the Southwest Development Commission and the Bunbury Chamber of Commerce about a forum on compassionate workplaces. So that, all these organizations can have some policies that guide the employees and the employers on how do you make sure that your workforce know what to do when someone is caring, dying, or grieving. Not run away. Like we had one, somebody with us in the group, she lost her child, and then when she came back to work, she used to work in an open access space, and she found out they put her in a room by herself with a locked door. And all she wanted to do is be back with her friends and colleagues. Why are they doing this? They're protecting themselves from her pain because they don't know how to face her pain. So by locking her away, they don't have to see her or think about that. I mean, this is what's happening. You hear a lot by, some people, they know that the neighbor have lost someone, they try to cross the street so that they don't have to meet them on the same side of the pavement because they don't know what to say. I mean, that's not difficult, but we need to learn it, It is something that we need to learn. So this needs to be sustainable because it is something that's going to bring values to life and death in a community. And it will inform sustainable skills and policies and structures, as I said, for all the workplaces, the schools, the faith organizations. And it will be informing future strategic community plans. Already in the Bunbury Strategic Plan, Community Engagement Plan, there is a section on having a compassionate community, so which is good. So this way, our services, facilities, programs will support quality of life of people who are experiencing hardship, illness, death, and bereavement. Now, as I said when I got the award, I don't know how it came out of my mouth among all the stress anyway, we only die once. So let's make it a good one. How do we make it a good one? We need to start having things happening in the community to make this awareness happening. So for instance, death cafes are everywhere. Have you been to any death cafe, any of you? It's not, somebody told me, I don't want to go somewhere to glorify death. It's not about this. People come and talk their experience and who helped them and who didn't help them. And people learn from them. Death festivals was about community education and awareness that we've done, and other people in the world, they're doing this. We always have visits to cemetery and crematorium. Very interesting to know how they do things. We have also on the 8th of August every year Dying to Know Days. It's become international. Again, more about public education and awareness. We have World Compassionate Communities Days on the 1st of November. This year in Bunbury, we're going to have a concert at the cemetery. Now, we'll see how it's going to go. And I got this idea when I presented at the International Compassionate Communities Conference in Bruges in Belgium last year. And the guy who presented after me was an artist, a musician. And he got this idea when his best friend died, and he used to play the guitar with him all the time, and he felt he just couldn't anymore. So he took the guitar and went to the grave there and sat there and started playing. And then his friends came with their beer and everything, and then the whole cemetery was in that. And then, so anyway, we're going to try this concert in Bunbury. Watch that space. We'll see how it goes. And again, we'll have those memorial floating lanterns. Again, that was really nice when people wrote the names of their loved ones around a paper-based lantern. And then it had a candle in it, and then it flowed in the water. And then it gives, this is like opportunities to remember and acknowledge, the people who were dear to us and they're not with us anymore. There's also a palliative care film screening called Live the Life You Please. That's in Palliative Care Week. The State Library is going to run probably parts of it on the 24th of May. And I'll be part of a panel there that's we will discuss things around palliative care. Again, all the regional centers are going to run it, Albany, Bunbury, Esperance, which is great. So it gives, the idea is to start those conversations, basically. Again, we're going to have the Compassionate City Charter now, and I advise the town of Cambridge to probably start this, and happy to, advise any local government who want to start doing this around compassion. And again, compassion is just not the end of life. That's why I call this growing compassion in life and death. And the way we live is the way we die, So let's start it much earlier on so that by the time we reach the end of our life, compassion is there for us everywhere. And again, I mentioned the award that I'm hoping, going to talk to our mayor, see if we could have something. Maybe Rotary clubs can have an award for this as well. It sort of brings compassion to everyone's mind all the time. That's the reason. So when we did the review of the palliative care services in our state here, those are the really pressure points. This is what palliative care is not, we call it the blind spots. Non-cancer conditions are not really getting the same level of palliative care as cancer conditions. Family carer support. Family carers need to be more supported than what they are. Grief and bereavement support is very ad hoc. It's not there, basically. Health and death literacy of consumers, that needs to be now there. Of course, with advanced care planning, WA Health and the Palliative Care Western Australia, they've been talking a lot about advanced care planning and, getting the death literacy of consumers there. So they're doing a fantastic job. Workforce education and training, that's WA Health. They're doing a lot of good things in that respect. And then they talk a lot about models of integrated care, but we don't seem to be integrating anything. We talk about it all the time, but we're still in silos all the time. So this is the model that we proposed after that review. It's called the public health approach to palliative and end-of-life care, where you've got those services. They all need to be integrated, whether NDIS or aged care or the palliative care services or primary care, allied health care. And they're all around these circles of care, basically, but sometimes they don't talk to each other, or most of the time. And then the enablers, there's so many of those enablers that we have now, but I like to focus on compassionate communities because they are a big enabler in this integrated model if we're going to really support it more and get the community part of it, because they are enlarging social networks. The social networks are able to know about the services more around the person instead of, you hear a lot, one service comes, they want to take a blood test, and then the family carer says to another one that comes, oh, but somebody else has already taken blood test. Why are you doing this thing again? Because the care advisor, the family carer is the sort of the case coordinator for that family, because she knows who are the services that are coming and if they are duplicated for no good reason. So this is what we have to have, all this alertness in the community more around families. And not-for-profit organizations, they do a great deal of talking in the community. No health service professional is able to have that time. Time is a commodity in our hospitals and clinics. There's such pressure cooker environment. So anything that people have emotional preparation for end of life is not happening. Those conversations are not. But not-for-profit organizations like, say, Hannah's House, for kids, I presented to them yesterday. This is what they are. They are in people's home, providing respite, talking about what matters to people. Motor Neurons is association. I chair the association at the state level and also this year at the national level. Again, our care advisors go in, talk to people, see what their needs in everywhere, and connect them. The Cancer Council, like so many of those not-for-profit organizations, I think their status needs to be raised a lot more, and they need to work more in partnership with the health department, and I've said that to them. So, to finish, Give a Family a Fish is a charitable act. teach a family to fish is sustainability, organize a community-based intergenerational fishing collective, that is social change. And this is what we are doing. We are doing social change with that community, compassionate community approach to care. So I'd like to thank all these organizations that were part of this. Of course, you know, it was a big project when you have the community involved. You just need a lot of people with different skills to bring it all together. And then I'd like to leave you with this. Yep. End-of-life care is absolutely everybody's responsibility. And when I was asked by the West Australian, what is a song that actually exemplifies the work you do? And I thought that one. Absolutely everybody is in this. Absolutely everybody, absolutely everybody. Yep, thank you.